Okay, now we continue the fun. We're gonna continue with our questions. So, when you have a 55-year-old woman, okay, that on echo there is severe mitral regurg and myxomatous degeneration with EF of 65, okay? So what would you do for this patient? What is your treatment? Someone on echo should that when you see this on echo, okay?
So this is normal. I mean, the ejection fraction is good. It's just a regurg. Don't do anything. I mean, yeah, just like evaluate and screen.
Yeah, so basically you evaluate for mitral regurg, okay? If you just evaluate if there is EF is only 25, okay? So it's high, it's good. However, there are indications for surgery. Maybe you don't need to know the details, but just have in mind, like when the EF is when the patient is symptomatic. This patient is asymptomatic. When they say during routine exam, this means they're not symptomatic. When the patient is symptomatic, when the patient asymptomatic with low EF, okay, or end diastolic diameter more than 40, or asymptomatic who went another cardiac surgery for pulmonary hypertension or anything other surgery, on your way just replace the mitral valve, okay? So for these patients who are not asymptomatic and they have like some mitral regurg with good EF, then just follow up in 6 months to a year, okay? So now we have the 65-year-old man evaluated for 7 days after discharge of anestemy, okay? On exam, shows there's a bruit in the right femoral artery. What does that tell you?
There is a stenosis.
Yeah, there's some sort of stenosis. So the way you do cardiac rehabilitation or supervised exercise program, same thing. It's a fancy way of saying supervised exercise program for PAD. They try to trick us doing the questions in multiple ways. So cardiac rehabilitation, I just want you to be aware of. Sometimes they do that instead of supervised exercise program, okay?
Oh, that's another name for the exercise. Okay, got you.
Yeah, which makes sense, okay? Now, we have this old gentleman, old woman, old lady, that came in with chest pain and anestemy. On day 3, she develops sudden chest pain and loses consciousness, okay? So this is something they love this. They ask about this thing. What does that tell you? She had a STEMI on day 3. She had lots of consciousness.
Arrhythmia? Syncope. That's a syncope. Yeah.
Yeah.
Oh, wait.
What complications of STEMI happen on day 3?
A lot of stuff happened on day 3. The mitral regurg happened.
Which one that causes pulseless electrical activity?
Oh, I did not know that.
And heart sounds diminished. This is extremely important because on day 3 there are complications of MI. It's important to review, you know. On day 1, certain complications. Day 2, certain complications. Day 3, specifically 3 to 5, the fibroblast macrophages is going to migrate to the area of dead tissue and start eating up the heart. So they start eating the heart, increase risk for ventricular wall rupture. And usually it's deadly. The patient die. Okay? This is common cause of death after MI. This is something to keep in mind on day 3 to 5, okay? So now we have a old gentleman with low-grade fever, chest discomfort, and let's see. Okay, so low-grade fever, chest discomfort, lower extremity edema. Heart cath demonstrates equalization of diastolic pressure and an increased pericardial thickness. We just went through the same questions, right? What does that tell you? Pericardial thickness and the equalization of diastolic pressure on heart cath. What is your diagnosis? ESR is elevated. Hmm?
Yeah.
Yeah, so this one could make us think it's constrictive pericarditis. Okay? Whenever you see equalization of diastolic pressure and thickness, pericardial thickness on echo. Okay, now we have another one. It's very interesting. Is that history of heart failure, EF. So 70-year-old woman who have heart failure. Okay, and there's S4, no wheezes and crackles noted. So without wheezes, but there's a crackles. Okay. And the patient is on hydrochlorothiazide and diltiazem. What would you treat this patient that coming with crackles and JVD and lower extremity edema, but no wheezes, and he's taking hydrochlorothiazide?
Stop all the medication that decrease the heart rate, and then pretty much beta blocker, calcium channel blocker.
Yeah, basically give them Lasix, and you stop hydrochlorothiazide just to maintain euvolemia. Okay. This is like another way of asking questions. How do you treat CHF exacerbation? Lasix. Easy. Okay. So now we have a 47-year-old man with a progressive exertional dyspnea and associated with activation. So this is progressive exertional dyspnea. It's been going on for 6 months, and then CVP elevated. Okay. And constant splitting of S2. What does that tell you? What's your diagnosis?
That's splitting is ASD.
ASD, perfect. So this is an ASD. So this is something clue to keep in mind. They can throw in a grade 2 systolic murmur and grade 3 hollow systolic murmur at the apex. They can throw anything. But all of these features, it's not specific. You know, systolic murmur could be anything. But this is what the most specific. Okay? Whenever you see constant splitting of S2, just pick as ASD and move on. So now we have a 59-year-old man evaluated during routine exam, and history of significant for hypertension and performing aerobic exercise for 20 to 30 minutes 4 times per week. Okay. So this guy is young and just came into for routine exam. So what would you do for a guy from 40 to 75 years old and who just came in for routine exam? One of the things that you want to do, if you see that, calculate the 10-year atherosclerotic artery cardiovascular disease on MD calc, that'll probably be a right answer. Okay. If you see smoking cessation, that would be a right answer. Advice lifestyle, that would be a right answer. Okay.
To give us that or something.
Yeah.
Oh no, sorry, yeah.
Yeah, you advise you calculate if sometimes they give you the 10-year. If it's more than 7.5, then start statin. Okay. Now we got this old guy who had mechanical prosthetic valve. How do you anticoagulate? That's how the question. What do you use?
Oh wait, 1 second. My screen gone. Aortic valve. Oh yeah. Mechanical, let's show the thing. Yeah, you have to give warfarin.
Warfarin and aspirin. Okay.
I thought you also give warfarin.
Yeah. So, 75-year-old woman for palpitations, heart rate of 110 and intermittent irregularity. Okay. Exam shows tachycardia with split S2 and white complex tachycardia. How do you treat this lady that have white complex tachycardia?
Heart rate is the white complex, so the beta on the conduction. Oh no, that's AFib.
Yeah, intermittent irregularity and this make you think of AFib, so beta blocker anticoagulation. Okay. So now we get like a few more ideas. If you see a let's see, an old gentleman with a 5-month history of exertional chest discomfort that improved with rest, and stress echo showed 2 mmST depression. Okay. What does that tell you? ST depression, chest discomfort with exertion, improved with rest. Huh? No, angina, like some sort of angina, ST depression. If there was ST elevation, that's an MI, okay?
Oh, I never understand the difference with this guy, sorry. So ST depression is angina, right?
Yeah. Okay. And then there is also ascending aortic aneurysm. And the guy has also heart cath showed multivessel coronary artery disease. What would you do for this patient? So usually in real life, that's what consults general surgery, and they're probably going to do simultaneous CABG with aortic repair. Okay. So because there's some thoracic aortic aneurysm, they will fix that. So now we go to the next question. We have 37-year-old man with right-sided weakness and heart failure with ICD. Okay, you got the idea? Got the picture in your head?
Right side weakness. What is ICD?
Implantable cardiac defibrillator.
Okay, so yeah, it's a heart failure. Right side weakness. Okay, so he had a heart failure, now he has like a stroke went to his head.
Yeah, so this is just something to keep in mind. If someone have ICD and then they develop right-sided weakness and then you see loss of gray white matter, what does that mean? Loss of gray white matter differentiation in middle cerebral artery.
I don't know.
This is stroke.
Oh, that way, yeah, I got that.
Yeah, this is like just something you interpret, it's stroke, okay? So usually when you have a stroke, so this is what they tell you, like they could have asked you, okay, what's the complication of ICD? Someone develops stroke after ICD. What could be causing that? And then you pick left ventricular assistant device thrombosis, because it happened in 20% of the cases, which is a huge, 20%, like it's pretty huge. It happened actually 1 year, 20% at 1 year after insertion. They can have hemorrhagic and embolic stroke. Okay. So this guy, they could develop a stroke. They stroke out after ICD. So there are certain clues. They just say, oh, develop right-sided weakness with ICD, but they were kind enough to give us CT. Okay, but sometimes even if they don't give us CT, you gotta know that could be. That's likely, because everything is likely. Could be that. Could be something. Okay, got it. Now let's do this 50 so that we take rest after that. We have a middle-aged woman evaluated during a new onset visit with a soft hollow systolic click, mid-systolic murmur. Okay, does that make sense? Systolic click, mid-systolic murmur. Where? At the left sternal border and radiate. Without radiation, sorry, okay? And the patient is asymptomatic and the murmur does not change with respiration or hand grip and does not diminish to all of these things that we do. So it's just a soft murmur and does not have any other features of murmur. This is a very common questions, by the way.
Yeah, don't do it.
Huh?
Yeah, don't do it.
Yeah, I just do routine. What do you call this murmur?
That's a mitral prolapse.
No, this is a physiologic murmur. It could be nothing, Soft click, soft systolic click, 2 out of 6. Okay, without radiation, patient symptomatic, doesn't change with respiration, hand grip, doesn't change with anything, you know. If there was valvular abnormalities, then they tell you it changes with intensity, you know. There are some changes, okay.
Okay.
Those could be just physiologic murmur. So that is the summary of the summary. Okay. Thank you so much for listening.